panel. So we have my name is Aasim Padela. I'm from the Department of Emergency Medicine at the University of Rochester. The last panel, there was a cancellation. We're privileged to have an addition to this panel. So we will begin. I just want to say that the panel's title is Clinical Issues, and sometimes we become emotional. Just so you know, if you start having chest pain or difficulty breathing, you have an emergency medicine physician and a critical care attending here to take care of you. So don't worry about your emotions here.
Neither of us know anything about the pulse unless it's on the monitor.
So our first presenter will be Abdul Hakim Bishawi. He is the library manager of Maktoum Harvard Medical Library, Dubai Center. He's doing an internship for 5 months here in the United States and is at Simmons College in Boston. In his previous work, he worked at Talam Hospital in the UAE as a medical librarian. He was there for 10 years and then worked as a deputy medical librarian in Palestine. He has a diploma in library science and a bachelor's degree from Al-Najah University in Palestine. He also has a master's from a university in the States. He has given multiple presentations, and today he's going to be talking about medical ethics, how health librarians are involved.
Thank you, Doctor. Assalamu alaikum, everybody. Good morning. Let me first thank John for arranging this conference, as everybody thanks him. And I'll thank him again for allowing me to present this talk and add it to the program. Actually, it wasn't in the program itself, but the idea came by accident when I met him yesterday morning, and I found that there may be some cancellations from speakers. So for this reason, I suggested to talk and present something about the medical ethics, and which I think you may not know about it for medical librarians and the role of health sciences librarian in this topic, actually. At the beginning, I'll let you know that there is no doubt that librarians, especially health sciences librarians, play a key role in healthcare. The number of services, the services which we provide for healthcare professionals, for patients, for staff, medical school students, and patients are appreciated by many people in healthcare team. Due to the rapid dissemination of information, healthcare professionals, it became hard for them to control the information and follow up with what they need exactly. So the librarians, I'm talking about health sciences librarians, they organize this information, they make it easy for them to locate and find it. They provided them with remote access to the library databases and online journals from any place in the world, which is a great service. Okay, and the professional library associations in the US and Canada, actually, they protected health sciences librarians by providing or by creating code of ethics for them to protect them, in order not to be questioned. So for today, we'll talk about this code of ethics, which were created for health sciences librarians, and I hope you'll find them useful. So I'll start with one slide here about the Harvard Medical School Dubai Center. Actually, it's not advertisement, but since it's a new postgraduate medicine institute, actually just for your information, it's called Harvard Medical School Dubai Center, HMSDC. It's for postgraduate education and research center. It was established to foster the professional development of physicians, nurses, research scientists, allied health professionals, and medical educators in the Gulf region. It was launched in 2004 as a joint effort by Harvard Medical International and Dubai Healthcare City. It's part of the government of Dubai's mission to develop the DHCC into a center of excellence for healthcare delivery, medical education, and research. If you have any questions, or if you would like to chat with me about Dubai Healthcare City or HMSDC, you can do that in the break, not this talk. Okay, now you started yesterday, and what I tried here, actually, I worked on my slides for like 4 to 5 hours last night. And I came with something, and I hope it's like I tried to compare between what you presented yesterday as physicians and what I'm presenting now. Some speakers started yesterday with cases, and here I have a case for you. This gentleman, he's Robert. He's a library. In 1975, he was a library science student. Then he visited 6 public libraries and 7 academic libraries to seek reference, help in locating information that would help him to learn how to build a bomb. And the case became a textbook. Fortunately, that this case became a textbook of the case, so the conflict between the personal and professional roles in librarianship. Why that happened, do you think? Because now those librarians, reference librarians who they visited, should the librarians refuse the patron's request on ethical grounds? And some of them, they found more about patron's possible clinical intent, criminal intent. Is reference service a value neutral professional activity which prescribes any consideration apart of the technical questions of how to access the information? There was some discussion about that. Why didn't they provide them with the service? Some of them, they said, you are not a student at our college, we can't provide you. Some of them, they said, this is like, they didn't tell him that this is risk information, so you may do something bad. But at least, from this point, like, those professional associations for librarians starting thinking about the ethics to protect librarians. Now, ethics, I read an article yesterday. Fortunately, I went to the library here, and I found it's an excellent library. I encourage everybody to visit it. And they have resources about ethics. I found it excellent. And there is one article that was published by Elizabeth Bachnan at the Journal of Information Ethics, 2004. This is the reference. And yesterday, Dr. Billa presented about teaching ethics or teaching medical ethics. And now here, this librarian, she did a search about teaching ethics for librarians. Is it part of the curriculum for the students who study lab information science? And she found this results that one class only is called sometimes ethics in librarianship, ethics in information, ethics information science, but it's one class. So she came with these results, and from this point of view, we can encourage like schools and to add this teach ethics, more ethics classes, and for students. Who are our clients? Healthcare professionals, nurses, physicians, physical therapists, excuse me, and what do we do for them, actually? They obtain, these healthcare professionals, they obtain the information, they visit the library to obtain and locate the information which they need. However, the new roles for medical librarians, it was promoted, and now we go to healthcare professionals. There is a new roles for librarians which calls clinical medical librarian or morning reports. The librarian join the team of physicians and nurses in the morning when they go through the round and visit patients. Why is that? To provide them with information at point of care, evidence-based information, through using the technology tools, which they like PDA, personal digital assistants, handheld devices. This is an excellent excellent service which was added, and it was appreciated by healthcare professionals. And here in the US and Canada and UK, actually, they use it. Unfortunately, this service is not used in the Middle East until this minute, but I hope we'll provide it at Harvard Medical School in Dubai Center, inshallah. Now, medical librarians, they educate healthcare professionals, educate them how to locate information through using the remote access to the library, how to get an access, how to use the electronic databases and online journals, which they need to get information for education purposes. The other, we help, as you see, the medical students and their teachers, faculties, researchers, and patients and their families. I want to focus on these patients and their families. I did a search at the Gulf GCC libraries, medical libraries, and I found, and I think one library only offers the services to the patients or their families. The service is not available in the Gulf region at this minute, but inshallah we'll start with that. So at Harvard Medical Center, there will be a patient education library which will include the print and electronic resources which will serve the patients and their families. Now, they might be called consumer health libraries. They provide excellent service to patients. We don't provide medical advice. So when patients come to us, we tell them which resources they can find information about their cases. We make sure that there will be no conflict between what physicians told patients and what we tell them. We don't provide the advice itself. However, we give them brochures, pamphlets, articles about their cases. And And interpreting is a very important issue actually in this case, because we might be visited by patients from different nationalities who speak different languages, and in this case we want to make sure that we provide them with the correct information, accurate and evidence information. We watched the movie last night, it was great, and we found there was a problem. The movie entitled Hold on Your Breath. It was great that we found there was a problem interpreting between the daughters of the sheikh who died, cancer patient. So interpreting is important. People who will do the interpreting translation must sit for a medical terminology actually test to make sure that we'll provide the accurate information. There is no control on the website, so anybody can publish any article or information on the web. So we need to make sure that the websites which we use as healthcare professionals must be evidence accurate. There is criteria to evaluate those websites actually. I found that there is a low information literacy, so librarians educate patients and their families how to use the medication, and there was many statistics, many articles were published in the website, in the internet and journals about this low information literacy. So librarians play a great role in that. Now this conference is important for me. Actually, I attended this in 2002. There was an international conference for ethics, and it was held in Abu Dhabi, and I made use of that. Okay, so now management of information. This is to prove that the goal of information management function to support decision making, to improve patients' outcomes, assure patients safely, improve performance. And hospitals' provision of care, treatment, and services is a complex endeavor that is highly dependent on information. We want to make sure about these informations. And here, to achieve the vision of effectively and continuously providing improving information, we need to follow these two things: ensuring timely and easy access to complete information throughout the organization. This is for patients, for healthcare professionals, for our clients. Now, so we have the professional associations, library associations like MLA, medical library associations. They created code of ethics for medical librarians, for healthcare professionals. CHLA is the Canadian Health Library Association. Actually, I'm a member at both of them. They joined together, they put the code of ethics for medical librarians to protect them. And what are these code of ethics? This is what my profession says I should do. This is what we need to say for people. The code gives me, as a medical librarian, the ethical standards I need to enable me to determine the right thing to do my practice. A code will not tell you the specifics of practice. However, it cannot give you a specific answer in academic situation. But it will give you an ethical standard to which you can hold your question, your ethical dilemma, your ethical difficulty, to help you decide how to act. Okay. Now, code of ethics for health. The health sciences librarians believe that knowledge is the sine qua non information decisions, healthcare education and research, and the health sciences librarians serves society clients. Society, in terms of society, this is what we came up with. And in terms of client, this is what we need to do for clients to make sure that they will get their information without any discriminations for their nationality, color, or religion. And for institutions, we provide our services to institutions. I want to make sure that we provide leadership of expertise in the design, development, and the ethical management of knowledge-based information systems. And as a professional, advances and upholds of the philosophy and ideals to the professions, advocates. These are like exactly, you presented yesterday about these things. You presented about ethics, medical ethics for healthcare professionals and medical students. And here we do that for health sciences librarians. So for self, this is what we have for self. Health sciences librarians assume personal responsibility for developing and maintaining professional excellence. So, are you agree with me that the medical librarians are involved with this topic, what you are talking about? Thank you.
If there are any questions, we have a few minutes. If there's any specific questions for Abdul Hakim.
So I'm Amy Wendling. I'm a philosophy graduate student here. I teach bioethics. My question for you is, you introduced a kind of dilemma about what information should and should not be made accessible, but I don't think you answered what the librarian's what you think the librarian's role in limiting or giving access to that information should be. So I wonder if you would answer it.
Yeah. What we do as a librarian, as I told you, we don't provide the medical advice itself. However, we provide you with the information. We use the evidence-based websites and information through the print and electronic databases to provide you what you need exactly. We don't have, especially when we deal with patients, we are worried when we deal with patients actually to make sure that there will be no conflict between what physicians told patients what we do. So this is, I hope, does it make sense? Or
I'm asking, though, about limiting, say, for example, information to how to build a bomb. Right? Do you take your role to be that active? Or, on the other hand, I can imagine a situation where I might want to make information to a patient that contradicts what his or her physician has to say accessible, such that they could read the literature themselves and think maybe I might go for a second opinion, something along these lines.
If the patients, for example, they have high standards of information literacy, they can do that. However, they come to us, and as I read some articles about low information literacy, especially in the American and other countries, not only here, for patients who, for example, carried their prescriptions and they were walking, and because they have low literacy, they couldn't use the medication as the physicians described it for them, and this led to side effects on their cases. So when these patients come to us, we don't tell them take this medicine, don't take this medicine or take it. However, we provide them with the pamphlets about medications until they have to look at it. They have to find it themselves. Actually, new roles actually were created. The reference service, the reference library service, it was promoted actually now. The checkout system, for example, you can do yourself. You can do the checkout for the books. You enter your card and take it. In collection development, for example, collection development and acquisitions for the library. As I am a collection development librarian and I work on that, I have to respect the ethics. When you suggest a book for me, a resource to be added and purchased to the library. Now, there are some questions about copyright. Law and copyright, is there a law? We need to protect the librarian when we send you an article, a full text article. As a physician, you don't know what we do exactly, actually. We organize this. We negotiate the licenses with publishers and vendors to make this access easy for you. See, when you got the remote access to the library, you didn't get it in 1 hour. The negotiating the license and the agreement with the publishers, it may take like 1 week, 2 weeks. We keep going forth and back and add some words and change some words in the license and the agreement itself to make sure that the access is not limited, for example. And these publishers actually, sometimes they made it difficult. And at the beginning, like in 2000, publishers provided each medical library who subscribed to printed journals to get a free online access if you subscribe to the printed one. In 2002, they limited the access for 3 users. Now, you cannot do that. You need to subscribe to online journals themselves. It's very costly, so we need to increase the budget. Many questions we receive about the copyright, actually, and we want to make sure that we'll not abuse the copyright with the vendors. And thank you.
Could I add something to that question in response? I think that in addition, in your question, there are some issues about autonomy and so forth. That we can come back to those in my comments, because I thought that some really interesting points were raised here, including that it's not surprising that within a site that's dedicated to medical care, a point of view would be reflected in policies. But also that has to take into account the fact that outside of that site, the information marketplace is totally wild. And so there are questions about, what you actually accomplish by limiting as opposed to trying to educate. And then, as you say, differences in literacy in the populations of users make a big difference. So I think you're touching on something that'll be really useful to come back to.
Thank you. Just a reminder, myself and all of you, that when we speak, just introduce yourselves before you ask a question or respond. So the next presentation is by Hasan Shanawani. He's going to be presenting his paper, Reporting on Islamic Bioethics in the Medical Literature. Where are the experts? So Hasan Shanawani is an intensive care physician at the University of Michigan. where he's investigating the end-of-life care needs of Arab Muslims living in Detroit. He trained in critical care at Duke University, where he was also a fellow at the Center for Genome Studies, Law and Policy. He was also a hospital chaplain serving Muslim patients at the Duke Hospital and a faculty mentor for Duke chaplains. He is on the ethics committee for the Islamic Medical Association of North America and the strategic planning advisor to the American Muslim Health Professionals.
After Abdul Hakim's example, if there was any doubt about the AV system working, I'm sure the FBI's backup system will be working fine here. I attempted to convince Dr. Brokup that I should change the subject of my talk to a different subject. As it turns out, it turns out it's a moot point. Duke, as well as the other top 1 seeds, have all been knocked out. The NCAA, for those of you that don't know, is of course the Collegiate Athletic Association in America. It is a uniquely American institution. I will be talking about Islamic bioethics in the medical literature. Dr. Khalil, who is a PhD student at the University of Michigan in Islamic Studies, sends his regrets that he was not able to join me. He is my co-author on this paper. Something about a Wolverine coming onto the Penn State campus, I think, is what he was saying. These college rivalries are something that are really special to America, as are a number of things. I'm not making these comments gratuitously. I just invite the audience to ask yourselves, just sort of take a survey to yourselves, how many of these terms are you familiar with as you look at this list? I'm sure all of you know 1 or 2. As the list gets longer, fewer and fewer know perhaps all 18. You cannot, and I would defer, of course, to the bioethics teacher here, you cannot study bioethics in the United States without knowing the cultural history of medicine, its best, the best that it offers, and of course some of the worst. And these examples are a number of them. Hard to figure out what an ethicist does sometimes. We talk about sort of different things. Really, the only point that I wanted to make is that here at this particular conference, I really have been very impressed with the different disciplinary approaches that we are all taking under this umbrella that we call Islamic bioethics. I want to point out that I am a clinician struggling, as many of the clinicians are, with some of these questions. I'm an amateur social scientist. I am not a religious scholar. I'm certainly not a fatwa hunter, as Vardit said yesterday, nor am I a historian of Islamic studies, as Dr. Brokup, as Jonathan. So I bring my own disciplinary focus to this. As a physician, this is what we see, some of these articles as we struggle with some of these questions. And Abdul Hakim is a perfect example of when we do have questions, what we look for. And these are examples of a number of the articles that you'll find in the medical literature. And I wanted to sort of talk about when we try to interface with these questions that we face in ethics within the Muslim community as either practitioners or as patients, what it is that we see. I want to talk a little bit about how I address bioethics questions and where my disciplinary focus is. Obviously, we ask a question in a case presentation, for example. We try to identify certain aspects of it, certain key terms that we're very interested in, relevant facts, for example, science, current practice, what are current standards of practice among professionals, what we don't know about a particular medical entity or biomedical question, who are the stakeholders, and most importantly for ethicists, what are the issues and principles. I personally am someone who looks at the facts specifically, and I try to identify as a professional and as a physician the stakeholders, and that's really my disciplinary focus. I am not someone, however, who is well versed on Islamic principles of bioethics. And I really do believe that all of these different pieces of the puzzle need to be addressed quite separately before we come together in such a forum to really address one another and really come to answer questions. It doesn't end there. There's a whole long list of steps, and this is referenced, and I will talk about this. There is a history of bioethics in this country in an attempt to try to get this information. Vardit's book from a few years ago is an example of a wonderful empiric approach to looking at, as she put it yesterday, fatwa hunting. Really incredible book. More recently, Dr. Yaqub, a cardiothoracic surgeon in Great Britain, wrote a book looking at the different Sunni madhahib Contrast that with the book Islamic Perspectives of Medicine, written by Shahid Athar, a senior ethicist in the Islamic Medical Association, which takes a more general physician approach. And of course, the Federation of Islamic Medical Associations, which has taken a bunch of physician consensus statements together with a limited amount of input from devotional religious scholars. As Aasim mentioned, I'm an empiricist, and I look specifically at issues in the ICU. I won't talk about these too much. A reminder, with security issues, we cannot talk about bioethics in America without talking about distrust of Muslims of the system, which is really a big concern. For those of you that don't know Brandon Mayfield was an American convert who was identified by the Department of Homeland Security when he was attempting to get on a flight through a faulty fingerprint mechanism, and he was arrested because he was confused with a terrorist suspect from the Middle East or Afghanistan. Unfortunately for the authorities, Brandon Mayfield is also a senior lawyer for the ACLU, and so it went pretty far. Identifying end-of-life care issues in the ICU, I think, can be divided broadly into two different sections. Patient barriers, which I'm not going to be talking about today, but of course, we all have these interests in what the physicians call cultural biases, which is of course suggesting a sort of central authority of us as physicians, which I don't pretend to endorse, and of course physician barriers, and specifically the fact that we are not formally trained in addressing some of these very difficult, nuanced issues, that we don't feel that we are qualified to answer some of these questions. We are unable to get at patient-family concerns. Last night's film was a wonderful example of this, and of course we too come with our own cultural mores and our own constructs that we want to look at. There are some real questions about how ethnicity and religion and geography affect your decision-making medically, independent of the medical quote-unquote facts. And a fatwa is not a fatwa is not a fatwa, as Shireen Hamdi's article so nicely put yesterday. To assume that Muslims alone are driven to act exclusively by religion apart from any of the other factors that shape our lives is more than absurd. We interface as Muslims on so many levels, and we need to incorporate all of these, especially in a uniquely Western or American context. An example of this slide does not read very well, and unfortunately, oh, here's the laser. If you look over here, international differences in end-of-life attitudes. This is an article written by one of my peers in the critical care literature. And what you see is that people or professionals are more or less willing to apply written orders to end life or withdraw life support. Compare the United States, where they're quite willing to apply written orders. They're not willing to apply verbal orders, as opposed to Turkey, where they're not willing at all to apply written orders, but quite happy applying verbal orders. And there are some cultural nuances that reflect this and some realities that I won't get into today. Just to talk about the culture of, as we understand it from the medical literature, so that we're clear, this may not be the actual reality, but this is what we see in the medical literature. If you look, you might glean from certain articles, for example, that the institution of hospice does not exist in the Middle East, that people who are being sent home, quote unquote, to die do not have any follow-up at home, that they are less likely to, if they're about to die, that they're less likely to endorse things like the do not resuscitate, known as the DNR order. 37% among people in a neonatal, a baby ICU, which is less than the 55% that is reported in the medical literature here in the West and in the US and Europe. There's a number of examples. Here's an interesting one that I think you might take interest in. A survey of quote-unquote senior scholars in Muslim countries, all of whom reject the concept of brain death, until you take a few of them aside and say, hey, we'll tell you what, let's talk about this a little bit. And I don't know, they don't explain what happened here, the 7 of 9 that changed their mind with quote-unquote information, and how coercive that was, or whether there was really a dialogue, or whether there was sort of a bit of a used car sale that was made there. Interesting article about anesthesiologists and the culture of medicine here. They believe that 68% of them believe that when having this end-of-life conversation, that you need to have this coalition of the hospital ethics committee patient, but it only happens in 15% of the time, and there are reasons for this. We were talking yesterday about truth-telling a little bit. Here's some interesting facts. They surveyed people in the Emirates about this question, and they asked a question here. A patient is almost certain to die within the next 6 months. Should the doctor tell the patient? What you see here is when they asked the physicians, only 8% said yes, but 30% of the patients said yes. So even when we talk about people they don't want to know, I think we make assumptions about our patients that may or may not be accurate, and we don't know. The reality is I don't know, and I would argue neither does anyone else. Okay. We have to talk about cultural issues here. You cannot talk about Detroit Arabs and Muslims without talking about the history of immigration and Henry Ford. This is the Rouge plant, the first plant of Ford. Get any car you want, any color you want, as long as it's black, was the original comment by Henry Ford. Henry Ford also had his own history of cultural issues, most notably his history of anti-Semitism, which we cannot escape or ignore as Muslims in America. Again, going back to what's out there, let's talk a little bit about this. I think a lot of these nuances are missed in the medical literature. More to the point, the majority of scholarship in Medline makes little or no discourse on the existing discourse of Islamic studies, okay, that found in other peer-reviewed journals. And more often than not, articles claim this immutable authority. Islam says, Muslims believe. Let's take a look at what we found. We did a Medline Boolean search. I will defer any questions about my library search to Abdul Hakim, and specifically Islam, Muslims, or Arabs, and bioethics. Bioethics is a subset, a special design search designed by Medline for people who are interested in doing bioethics literature searches. This is what it looks like. We got 497 citations. We did an abstract review. This is what it looks like. This is about a third of the search. It automatically does this search for you if you put in the bioethics subset. It's a wonderful thing. This is about a third of the entire list. I don't intend for you to know this. We tried to limit those 500 articles by either quote-unquote studies about birth, pregnancy, cloning, and the like, transplant, solid or hematologic, death, and general bioethics articles. From this, we kept 146 articles from that review. We tried to limit, we tried to assess what concepts of Islamic jurisprudence were brought into the articles. If you are making a statement about what Muslims believe, on what basis were you making that? Did you cite Quran? Did you cite Hadith? Did you cite madhabs, group consensus statements? And we tried to do this in a quantitative fashion. And by the way, the articles are available. Some people had requested. I'm going to give a copy of the articles in PDF format, with the exception of about 20 of them, to Dr. Brokup. If you're interested in getting those PDF articles, I would just, we'll try to make them available. Within academic circles, it's allowable, but we are looking into that. You're absolutely right. Most of the articles were general bioethics articles. About a third of them were about abortion or some issues at the beginning of life, if you will. Some of them, a small number, were end-of-life organ transplantation, and a number of them were quote-unquote empiric studies of Muslims. Not so much normative articles, but rather social science studies of either patients. The articles, the journals, were mostly from Europe and the U.S. Abdul Hakim, you can comment more on Medline. This reflects the focus of Medline compared to Embase, which is a more international database, which is a little harder to get in the US. And Medline is what physicians more often use here in the West. The articles also came from South Africa, a number of journals rather, the Middle East, Canada, South Asia, and Southeast Asia, compared to where the authors come from. Most of them came from the Middle East, and those that came from the Middle East came from only a few countries. No, other than these 5, no countries produced more than 5 articles in terms of author or geographic origin. The US was quite strong, Europe, Africa, again. Canada produced 4, Dr. Alba is here. And those are, I think 3 of those 4 are yours, if I'm not mistaken. Types of journals, mostly were specialty medical journals. And I want to point this out because of the fact that peer review is going to be done by doctors, not by ethicists or religious scholars in these journals. So when they're reading these articles about Muslims and Islam, they may not have any working knowledge of the nuances of Islamic jurisprudence. Let's talk a little bit about what they cited. So of those 100 articles, only about half of them even mentioned the Quran at least once. Draw your own conclusions from that. About a third of them mentioned at least one hadith, or at least referred to it. This is not even actually quoting necessarily a hadith, just saying that they even exist. Okay, 35 articles mentioned the madhahib. Of those mentions of the madhahib, only 7 of the articles actually mentioned a fiqh decision based on a madhab. They just mentioned the existence of the madhahib. Legal principles, maslaha, ijma', qiyas, were mentioned in about 18 articles. Historical or recurrent citations made a number of them. I just want to sort of gloss through these and really get more to the discussion. How many of these sources were cited? So let's go back for a second. If you look at if you look at those 9 lists, those 9 categories, only 5 articles mentioned 6 or more of them, suggesting that there was this broad basis to them. About 13 articles mentioned 5. Most of the articles mentioned 3, and unfortunately, 13 articles made no citation whatsoever of any of these juristic sources. So in other words, they made Islam saying, I don't mean to suggest that what they're saying is untrue, but in the spirit of peer review, On what basis are you making these statements is the only question that I wish to ask. What is the process by which you came to this conclusion so that we can better understand it? Claims of universality, I'm just bringing a few. There are more mentioned in the articles. These are some of the comments that they got to them. The Muslim Legal Council of Great Britain is a body to Muslims, that what the Vatican is to Catholics. Muslims prefer to die in their own homes. Strict Muslims will not agree to organ transplants, and the subject should not be raised unless the family initiated the discussion. Only 5 articles mentioned Shia exclusively, and as an additional 7 mentioned both the Shia and the Sunni. One article went so far as to say that Muslims have no sex, but there are 2 major schools of thought in Islam, the Shia and the Sunni. 11 of the articles refer to this deliberative process that I'm trying to get at, trying to say that, listen, it's not so straightforward, that the Muslim scholars are really struggling with some of these questions, and that 5 of the articles suggested that this was an ongoing process, that they were still deliberating on this, on these different things. I mentioned that 7 mentioned a madhab opinion. Does Islam even concern itself with articles? There was only one article that even discussed the sources of reason versus rational. Again, I would defer to some of the other articles, Dr. Stern, who just gave a wonderful presentation about the debate between the Ash'ariyya and Mu'tazila, for example. Only one out of all of the articles that we reviewed even mentioned the existence of this debate. Okay. So some of our conclusions, that there was this big geographic disconnect, that people were writing in Europe about things that were going on in the Middle East and elsewhere, as opposed to people in England writing about things in England, people in the United States writing about things in the United States. Most articles were not in journals of ethics. Few articles suggest or present a diversity of opinion among Muslims. That there was this very superficial representation of the primary sources. They did not go into any depth. I didn't actually go into this, but this is in the paper. Virtually, there was no representation of secondary sources. There was no representation of the Shia, virtually none. No representation of the madhahib. And so what? I mean, maybe we don't need to do nuance. And maybe as physicians, we don't necessarily need to know all of these subtle details. And that's the question that I would have to ask. I think there are some interesting questions that we can ask these authors. To what extent are these authors familiar with this religious discourse? I think this is a question that we do need to be challenging these articles when they presented the medical literature. What are the general materials and approaches utilized? I want to know how they came to their decisions. Not to question the approach or anything like that, but really just to better inform me as a physician when I'm having these bioethical discourses. I want to have those tools. I don't have a lot of tools in my toolbox as a non-bioethicist or a non-devotional scholar of Islam. And if the legal framework is used, what methodology was imposed? And is there this reference to a spectrum of viewpoints? How allowable is this quote-unquote shopping around for questions, if you will? And what about other religions? And again, I'll defer to the librarians in the audience. Let's just compare very briefly. This is cited, and I forgot the citation. What was the name of the author?
Pablo Rodriguez del Pozo.
He did an interesting comparative study. I did the same cert. He basically shows in his article that Islam is underrepresented in the medical literature. If you do the same searches that I did, and Islam and bioethics, as I mentioned, you got about 500 articles. If you use the same approach using Judaism, you get about 1,300. Christianity, you get close to 5,000. On the other hand, if you do Buddhism, you only get about 120. So quote unquote, the non-dominant European religions are not represented in the literature. And I believe that is incredibly problematic. At the end of the day, I'm really not sure what it matters. For all of the papal discussions in Catholicism, I think the most important statement that was made in Catholicism was that when the Pope was about to die, he did not seek care. And that is a comment that has been made by a number of Catholic scholars. For all of his discussions about the obligations to seek care at the end of life, to not withdraw life support, to not refuse life support, he refused it at the end. Scholarship in bioethics and what bioethics it may be is what the next person might say it is. Especially for me as a physician, that is something that I always need to be concerned about. At the end of the day, this is what we need to be concerned about. I'm stuck here at the bedside, and I could really use some help. And this is really an open invitation to my new community of peers to hopefully an era of interdisciplinary research. And for that, I want to thank you, Dr. Brokup, for inviting us. Thanks so much.
Thank you, Dr. Shanawani. We're going to continue with the next presentation. Hold all questions for the end. So now presenting will be Dr. Tahereh Mosavi. She is presenting on the disability and bioethics in Iran, the religious beliefs of parents and their decision to continue or stop treatment of children with cerebral palsy. She has an academic background in occupational therapy and worked for several years as a therapist in rehabilitation clinics in Iran. Then she pursued higher education in the philosophy of religion and now is a doctoral candidate in comparative ethics and religion at Concordia University in Quebec.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and hello to everybody. My topic is about disability and bioethics, a case study of the role of religious belief of the parents in treatment of children with cerebral palsy. There has been a large amount of published clinical studies which have indicated a recent interest in the role of religious in medicine. This research is concerned with both the social model of disability and bioethical study. Although the medical model has a major responsibility and role for helping disabled people, many of the fundamental concerns of persons with a disability are not about medicine at all, but about social and cultural issues which are associated with a disability. Bioethics usually are concerned with a cure and ignoring the duty of care, but must pay more attention to rehabilitation care, which is a longer-term care. As we know, rehabilitation care differs from acute care medicine. Rehabilitation greatest emphasis on educational model. It's needs for the family to take an active role in decision-making and caregiving. One of the ethical decisions about rehabilitation care of the disabled children is the family commitment to follow the longer-term treatment. In other words, rehabilitation treatment, especially in neurological cases, require a long-term process. The family commitment in the continuing treatment of disabled children is necessary. That is, without the cooperation of the family, the rehabilitation treatment of these children is impossible. The family's commitment is related to many factors, from their economical, educational situation to their religious and cultural background. This research was intended to pay more attention to rehabilitation care and bioethics. The effect of religion on health would be easiest to see in person and their family who experience serious illness or disability. One of the aim of this research was to examine the connection between the religious belief of the parents and their decision to continue or stop treatment of the children with cerebral palsy in the case of the Iran, which 98% of people are Muslim. Before to go any further, it is necessary to explain some important key terms. Cerebral palsy is caused by an injury to the brain before, during, and shortly after their birth. Cerebral palsy children damage the area of their brain and they have a problem to control their muscle tone. Children with cerebral palsy have some problems such as moving, talking, eating, mental retardation, and so on. Children with cerebral palsy often go to different kinds of therapy to help them improve their motor skills for things like walking, talking, and using their hand. Therapists are special teachers who are training to work with people on learning better to easier ways to do things. Physical therapy helps children learn better ways to move and balance. Speech therapy works with children on communication skill. And occupational therapists usually work with children on better ways to use their arm, hand, and upper body. This study was conducted from June 1994 to September 1996 in the Marjani Rehabilitation Center in Shiraz, Iran. During these years, there was just 4 occupational therapy clinics in Shiraz, 3 public and 1 private clinic. The patients were on a longer-term waiting list until they received the occupational therapy. The information was given to me as an occupational therapy by the family of the cerebral palsy children, some of whom didn't wish to give personal information. Thus, from 82 children with cerebral palsy, the information on only 43 was completed. This research divided family of these 43 children into 2 groups from the purpose of the study. Group A had continued the OT or occupational therapy treatment, and Group B had decided not to continue occupational therapy treatment. This research has studied 6 factors related to family decision to continue or stop occupational therapy of their children with cerebral palsy. These factors were the economic situation of a family, the clinical charge, distance from home to the rehabilitation center, the severity of a handicap, the educational level of the parents, and parents' attitude toward the handicap. This research was conducted in southern of Shiraz. The data were collected by me as occupational therapy in the Welfare Organization Center. Although this research was conducted about 10 years ago, the situation of this family in this region is still almost the same. As we said before, there were only 4 occupational therapy clinics in Shiraz, 2 were in welfare organization, while 1 was in a general hospital and 1 private clinic. The rich people were going to private clinic, and the middle class people were going to general hospital, and almost all of the low class people were going to welfare organization clinic. This is meant much of our patients was from the low class people.
That's okay. No back. Okay.
No problem. Okay, no problem. Okay, the back. Go back. The factor first. No problem. Okay. The first, okay, that's okay. The first and the second factors, economical and clinical charts, indicated that most people who were referred to clinical were poor people and their income was low. Most of these patients had a medical insurance from the government, that is, their insurance was covered their rehabilitation treatment. As we see, there were not significant difference in this factor between the family who did continue and the family who did stop the treatment. The third factor was the distance factor, which indicated those were living near the rehabilitation center. Their family was much more interested to continue the treatment. And the fourth factor was a severity of the handicap, which showed that the only family who had children with a mild cerebral palsy were interested to continue the treatment. Despite that, the 2 factors, distance and the severity of the handicap, indicated important differences between the 2 families. It is not the purpose of the study to deal with them here. The 5th factor showed that the most significant difference between the educated and non-educated people in continuing the treatment. It is obvious that the family commitment to continue their child treatment change as educational levels increase. The 6th factor about the religious belief of the family. When we talk about the parents' view, it's maybe only the father or mother or both of them. It depends who was responsible to bring the child to the clinic. 27 families of the 43 viewed disability as a God will. They had a belief that they should submit themselves to the will of a God. In general, this group had a positive attitude toward the God's will. 11 families viewed it as a bad luck in their life. 5 families had a negative approach toward God's will. They viewed the divine will as a selfish in its relationship with human. Broadly speaking, about 63% of families had positive view toward God's will. 26% consider it as a condition of life, and 11 had negative views toward God's will. Despite most parents in this research view disability as a God will. The question that may come to mind is why half of them. Okay. Why half of them? Okay. Why half of them stopped treatment and they didn't continue it? Does believing in God is well associated with ignoring human responsibility in their view as a Muslim? To respond to this question, I keep myself away from the disputed theological and philosophical discussion. Using the Quran as the main sources, I deal with that the Islamic approach on disability. Disability, as in the Quran, we can see disability as a God will. Disability is a reminder of the power of the greater than a human. Through the experience of disability, individuals are challenged to submit to this God's will and to achieve a fuller understanding of this power. And the disability as a God test. Muslim can view disability as a God's test, and at the core of the Quranic teaching is the belief that the life is a test. Suffering can be considered as the part of the test of the Muslim faith. Conclusion. God's will and human responsibility. What I found in this research is that the fact that there were not an inconsistency between religious belief of the educated Muslim and their cooperation to continue their child occupational therapy treatment, but it was not true regarding the less educated people. Less educated people worldview often live in a cloud of fatalism, which was the central target of the Islamic reformists from the 19th century. In Islam, God is the only sovereign and the power. Can a conception of the people's responsibility to duty to their patient be considered with an Islamic understanding of the God will? Believing in God will, according to Quran, doesn't mean to deny the place of the human action. Quran inserted the idea that God acts through human to further his purpose. The Quran considers man as the representative of the God in the world. That means that man really achieved his maturity without making God responsible for human injustice. Muslims have to pursue justice and well-being through their action. Believing in our responsibility and duty to care doesn't mean deny the God of power. Recommendation. The end. 1 minute. Although the elevated duty of care and human responsibility as an ethical good is too important, it is not the whole story. The disabled people and their family in most developing countries are those who are suffering the most, but they have been largely ignored. The family who have their children with disability have not the same quality of life as the other family in this country. Despite the emphasis of the Islamic tradition and the priority of the right of the disparate son, they suffer greater inequality. There is a large gap between disability policy and the reality about disabled people. My hypothesis is the rehabilitation treatment in this country is not sufficiently effective. Most developing countries suffers from many economic socio-economic and socio-political problems that affect health effectiveness. Thus, I would like to emphasize the prevention of disability as a necessity for every country. One of the ways of prevention of the birth of the disabled child is abortion. Having a disabled child is not simply a matter related to family. It is the work of the government to legislation of law. For example, abortion was completely banned in Iran, but recently the Iran parliament approved abortion in the first 4 months of a pregnancy when either the mother is in danger or the child would be disabled. But the legislation of a law also is not enough. This is the work of the government or government agency to plan a program to allocate specific resources for performing this law. Thank you very much.
We're now going to have our respondent, Dr. and Professor David Hufford speak. He's the chair of Department of Humanities at the Hershey Medical Center and an anthropologist by training. He's done research into the interplay of religion, culture, and medicine, and his department focuses on many areas of research about historical aspects of medicine, literature in medicine, film in medicine, and everything else about medicine. So I'm going to have him speak.
Thank you very much. I think we forgot to take questions on this paper. Shall we come back after my comments to them? Okay. I'll make sure, because I have some questions for you myself. Thank you very much. It's a delight to be here. What a wonderful panel and what a wonderful event. When I came to the College of Medicine in Hershey and joined the faculty in 1974 in the Department of Behavioral Science in order to teach about religion and health, that was a pretty eccentric thing to do. I knew essentially no one else actually who was doing it at the time. I thought I'd sort of made up the field in graduate school, and I was tickled that somebody would hire me to do it. It went very well. That's why I'm still there. But not only did it go well at Hershey, remarkably around me developed this great interest throughout medicine and throughout the country. Spirituality and religion are hot topics in medicine today. And bioethics, which was actually my department of humanities, was the first humanities department in a medical school in the United States, founded in 1968. And one of our initial faculty, Dan Clauser, is by many people considered one of the grandfathers of the bioethics movement. And bioethics has flourished also, become really an industry, some would say. So a lot of things have taken off in the little time little time. 32 years went by really fast. In a little time that I've been at Hershey, I won't take credit for having made it happen, but I certainly will tell you I have enjoyed seeing it. So what we're looking at today here is part of this flourishing of a really deep, complex, and centrally human aspect of the practice of medicine. I love being able to take part in it. And we are very much dealing with the issues that we're talking about on the panel here at our medical school. Next week, I am spending one full day with third-year students talking about problems of translation, interpretation, and religion, dealing with them together. One of the cases that we're presenting is a case of an Afghan immigrant who speaks only Arabic, who is Muslim, who has stomach cancer, and decisions about his care are complicated by family translators having different agendas and also different interpretations of the Islamic rules by different members of the family. And I'm being helped in it by my friend and colleague Mohammad who's going to be chairing the panel this afternoon, I believe. I don't see him in the room, but it's a great pleasure to be able to present a case, have a Muslim physician colleague there with me to talk about both the language and the religion issues. So we're dealing with them a lot, and I think that they're crucial to medical education. So some general points, and then I want to go to each paper, but a couple of general points about Western bioethics. One of the issues, and I think that it's indicated very clearly by Hasan's paper, but is present in everything that we're talking about here, is Western bioethics claim, at least implicit claim, to a kind of neutrality, despite its having arisen out of not only a particular cultural context, but being replete with input from both Jewish and Christian philosophy. And then within bioethics, I think it's really important to distinguish between the tasks of descriptive ethics, moral theory, and the practical ethics that we try to teach in medicine, which is informed by the others but cannot be the same thing. For one thing, we are not teaching our medical students to be bioethicists. We're teaching them to be ethically adroit and informed physicians. But actually, part of teaching them this is convincing them that they are not bioethicists just by virtue of being ethical physicians. That's another project. Anyway, there are certainly very different goals depending on which of these kinds of things that you're doing, and it is guiding the development, the formation of physicians, nurses, and other healthcare providers that we're engaged in. An analogy, too, that might help to see the difference would be to compare theology and religion as topics. Our students have to deal with the religious, they're beginning to be aware, deal with religious dimensions of their patients' lives, but that is not going to make the students theologians either. And actually, the amount that they need to study theology in order to do this, just as the amount of bioethics they have to study to be ethical physicians, is less than the professional working in that vineyard has to do. Well, so let's come to the specific papers. On Hasan's paper, first the library. On the wonderful presentation on informatics, there are two things that came up that I think concern me a lot, both ethically and in terms of practice, and I think that they were well pointed out by the presentation and by the question period. First of all, because of the flood of information and the speed of change in both fields such as bioethics and the social science of medicine, medical humanities, and medicine itself, the role of indexers and of electronic databases, and also of those who aggregate data beyond simply indexing it, such as the Cochrane collaboration that some of you may be familiar with, available electronically. These are wonderfully convenient things, and they make possible decision-making speed that would otherwise be impossible, but we have to recognize them as also filters and limiters of information. And you could see that in Hasan's paper, in part by what the Medline search returned, and if we had time to do another kind of study of that search, if we went manually through those sources and looked at what the search didn't return that would be appropriate to return, we would be quite stunned. as these sources and tools become more available and more effective, the likelihood that the consumer will go beyond them and actually be familiar critically with the information they come from seems to become less and less. This gives me great misgivings, because there's a kind of control that goes with that, a kind of authority that's implicit and automatic, that doesn't invite critical thought on the part of somebody who's in a hurry to get the job done. And there's a great deal of critical thought required here. So that's one thing. The other was the point about patients and families as consumers of medical information. And I'd like to just compare it, and then you can think about this on your own. Compare what's happened with medical information to what's happened with patient charts. When I came to Hershey in 1974, a patient caught looking at their chart because it had been left outside the door was likely to find the chart taken up to the nurse's station because they weren't supposed to look at it. Access now to your own medical record is a given. It's a natural part of the patient's right. The reasons for wanting not to have patients look at their own record were similar to the reasons that we had for not wanting them to read medical textbooks, have a PDR, etc. Well, they wouldn't really understand it. They might not make proper use of the information. They would become frightened. They would become confused. All of the things that an understandable paternalism sort of leads you to imagine. But with the information age, the genie's out of the bottle. You're not getting this one back in. And as a result, the only thing that you can do about this tremendous access and massaged access, as I said, through these indexes and filters, is teaching and educating people about how to use the information, not restricting it. Not that I think it's unreasonable for particular sites, say a patient education site within a clinic or a hospital, to have an information policy and a limited set of tools available, just as schools do. But just as schools need to remember, people leave those sites. If they have computers at home, they go back there, and then they see everything, including the garbage on the internet. And if they haven't been educated, as well as shown a limited batch of information, we're not serving them well. We have an obligation to help them to make those kinds of decisions. Well, back to Hasan's paper, I love the approach of using the Medline search as a kind of scholarship. I wish more people did it. Last year I did a large analysis of the field of spirituality and health for the Templeton organization, based in large part on an infrastructure of several different kinds of Medline searches. We need to be cognizant of the weaknesses of Medline in particular because of rapid changes on our kinds of topics. Somewhat this is true of bioethics, but it's especially true of topics of religion. When I was doing my searches, I was appalled at some of what I did get and a lot of what I didn't get. And it's because the people doing the indexing at Medline are not yet, at any rate, familiar with the topic. And they're applying old kinds of thought in an unsophisticated way, and it can give as a result very bad results. I mean, they're useful, but you have to know how limited those results are and have ways of going around them to do other kinds of inquiry, including going to likely sources and looking through the table of contents, something we used to do all the time back when we were using index cards for indexing and things like that. I have been around a long time. Hasan's search and the way things came up and didn't come up reminded me again of the issue of the difference between the discipline of bioethics and the topics of ethical decision making in the clinic, and including birth, reproductive issues, death issues, brings you all of the issues of bioethics concern. If they're linked with Islam, then you could say it's in the ballpark of Islamic bioethics. But many of those you would not expect to have bioethics disciplinary content because they're not being written by bioethicists. That is, hitting the topic of interest is not the same thing as hitting the disciplinary input. And there's an important conceptual difference there that bioethics and some other fields, I think, struggle with all the time. The difference, the fact that the name is applied both to the domain in the world and to the field that studies it. And not everything that's in that domain is comprised of the discipline. Hasan's point about universalizing, saying things like Muslims believe boy, is that a problem. And this field that we're talking about here today is an aspect of the field of cultural competency training in medicine and the issue of cultural diversity in medicine. It's a huge hot topic. Most of the people working in that don't think about bioethics, as far as I can tell. Most of them do think about religion. But again, because of the flood of information that seems to be relevant and the need to get the job done quickly, we now have, I should have thought to bring it, there's actually a pocket guide produced by Mosavi that will fit in the pocket of your white coat that has alphabetically arranged every culture in every country in the world with 3/4 of a page of the basic data you need to know about them as cultural beings to provide good care. That's a problem. It's a serious problem. Now, in my teaching at the medical school, I do have the opportunity, we do a lot of, our humanities department has lots of time in the curriculum, which is a wonderful thing. In the first 3 years, I get relatively brief opportunities to put in a couple hours here, a couple hours there on religion, often in the context of our bioethics teaching, which has more time in itself. It has 28 hours in the first 2 years with all students. But in the 4th year, I get to teach a seminar for typically about, I guess, maybe 15% of the class on religion and health. And we spend 50% of their effort for an entire month looking at this topic. And we do look at specific religious traditions, and we go into them in some depth. I have people come in representing those traditions. My colleague, Mohammad, who is here now, hi Mohammad, joins me for those seminars. I've often been able to bring in a local imam to the seminar when we're talking about Islam. That's a lot more depth. But you know, in the 2 hours that we spend on Islam, they do not become scholars of Islam. They get a little better understanding than they would out of that horrible little book that they could put in their pocket. The most important thing, I think, is that they begin to realize that there is behind what we're talking about a vast, complex body of material that they don't know. Now, what's the solution to this? It's the solution to make it so that all physicians do, in fact, have in-depth knowledge about all religions, all the major religions, all the religions that turn up a lot in their practice. I don't think so, because they're not going to be able to do it any more than they're all going to be able to speak the languages of all of the patients who come to them, any more than they're going to be able to be bioethicists. We really need to teach them how, being cognizant of how complex and rich the material that lies behind the questions that they have is, to make good decisions about how to elicit what they need to know from this patient, when they need to go from this patient to a referral to a chaplain. What a chaplain do in this case? Do our chaplains have competency to deal with the religious background of this patient? Or perhaps go through a chaplain to clergy within the community? And to what end? What are the implications of doing that for the decisions that are clinically important? Well, that brings me to Tahereh's paper, which I have a special sort of closeness to that topic because my adult son, David, who's 35, has congenital brain injury. He doesn't have cerebral palsy, but he does have very substantial developmental delay and some physical problems from this. And so I'm through my life experience with David and also through my familiarity with his peers, and being in the medical setting, I was often involved in sort of helping other families try to access or understand diagnostic and treatment services, and we had lots of occupational therapy and speech therapy and all of the ancillary services, and many decisions being offered to us about what to do or what not to do, what to continue, what to... Well, one of the things that is really clear in Tahereh's paper is the issue, and this goes to one of the questions about to what extent bioethics topics and some of the other aspects of what we're studying here may be looked at cross-culturally, where are the concepts that we can use to bridge. I would say, brought up pointedly and poignantly, the topic that a Western theologian would call theodicy. But even though that's a Western topic, it's actually, if you have a comparative religion view, you realize that in every spiritual and religious tradition throughout the world, theodicy is dealt with. That is, how do we reconcile the existence of suffering with whatever beliefs we have about God and about the spiritual dimension of life. So there are peculiarly Christian theodicies. Karma helps to constitute a particular kind of Asian theodicy. And there, in her outstanding paper, there are some beginnings of the development of what it looks like to see theodicy within the Islamic frame. In particular, I think it's very helpful that you don't have original sin, because original sin really complicates Christian theodicies. So I'm glad you don't. And the topic of fatalism also comes up. But to come back to theodicy, that I saw in what Tahereh was presenting an opportunity to say, well, you know, with some patients that I had become involved with, or with families who I saw dealing with the kinds of disability in a child that I was dealing with, I saw opportunities where I'd like to say, I would like to refer them to her. Because I saw, now if for a moment I imagined that 20% of them were Muslim. They weren't, but if they were, if I were dealing with Muslim families facing some of these theodicy issues that led people to say, there's no point in pursuing care. Actually, we might very well make an analogy to the Amish who occasionally make these kinds of decisions. No point in pursuing care except God's will, or actually, sometimes that actually has an, let me back up on that one. Let's go to the negative one that she brought up, that this is punishment by God. And that brings with it an emotional burden, as well as, from the medical point of view, bad decision making. Well, what do I want to do? Do I want to say, oh, I think you're wrong, that's not my understanding of God? Well, I can't say that to somebody who's not in my religious tradition, or maybe I can. If they're interested in hearing it, I'd be willing to tell them that. But to know that you can refer to someone who is of that tradition, who can help people to form a coherent change of view that is within that theological frame, is terribly important. And it comes back to Hasan's point about the issue of intra-group diversity, and not universalizing, not saying Muslims believe, Jews believe, Christians believe, Mexicans believe, African Americans believe. I mean, there are so many statements like that in the cultural diversity literature in medicine today. It's always counterproductive. But to be able to, this is one of the things that medical students need to learn, that within every one of the aggregates that we refer to, so here we're talking about Muslim patients, it's very useful to know what common tendencies turn up in the Muslim community, but you also have to know that every conceivable position exists there, and that there isn't a monolithic single directive. And you know, even if you go to those religions that have, you go to Catholicism, you've got the Vatican, you've got the Pope, you have dogma in a centralized way that you don't have in Islam. You have to know that about Catholics too. Lots of Catholics don't buy what the Pope says, even when it's ex cathedra, that there is diversity there. Go beyond that to Jehovah's Witnesses and blood transfusion that some of you are familiar with. There's probably no more hierarchical, authoritarian religious group than Jehovah's Witnesses. But you can't say Jehovah's Witnesses don't accept blood transfusions, because some do. And knowing that there's this diversity, so that when you come to the Islamic patient, it's really handy to know things like, well, there's perhaps a better than 50-50 chance that they're going to be somewhat resistant on terminating end-of-life care. At least that's something that I have read. That doesn't tell you anything other than where you might want to start with this particular Islamic patient. And then knowing the kind of thing that we heard in the last paper tells you that if the patient and family are saying, well, I understand that from the medical point of view, you don't like this decision, but this is required by my faith. This is what Muslims do. To know that there are Muslim leaders, physicians, imams, others in the community who can come in and say, well, you know, I think that we need to talk about that, because there isn't that monolithic position. Maybe that winds up being your position in the end, but you need to know that you are not required to hold that position, that you may have a misunderstanding in your theology. And I think it's natural that physicians will have a point of view, that is, they would like to deliver care that is medically indicated, and sometimes medically indicated care is contrary to the cultural norms of patients and groups that they're taking care of. And I certainly do not want anything to happen that allows physicians to impose that care. But I think that patients deserve all of the support that they can get in understanding from within their own community and traditional point of view what options may be open to them ethically and in a spiritually and theologically valid way that will help them to utilize medical options that are being offered to them. And if they can't, at the very least, get the kind of help, again, that I think was implicit in your paper, that coping with this disaster doesn't have to be on the basis of God's doing this to us because we're really bad people, but on some other footing that will give more emotional support, help with the spiritual and religious coping. And again, having an expert, and this is why I think Hasan's point is so important, that most of the people writing and presumably doing bioethics in the medical setting today don't have that in-depth knowledge about the religion, so they're not the people any more than my medical students are to help to create a theological opening for care. It's people in the community who are really knowledgeable and who hopefully share that patient's tradition, because it's not as if it doesn't matter whether they're Sunni or Shia or what their background is. Another mistake that we make all the time in cultural diversity, when we have people who speak the wrong dialect doing the translating, and because of those monolithic essentializing assumptions we've got. So I think that all of these papers, all three of them, do a wonderful job of indicating the challenge that we face for the practical bioethics. I was going to say at the bedside, but as you point out, it's not just at the bedside, and certainly not anymore with what we're doing with care now, which is much more dispersed, much more home care, much more care in the community. The bioethics concerns, which have tended to be largely focused within academic healthcare and within academic health centers and colleges of medicine, need to get out the door and be looking at the community and the care being provided there also. So I think that these were terrific contributions, and I'm going to assign them all to my students. Thank you.
We have a few moments for questions. The Hakim, come up here.
Thank you very much for this wonderful papers. I have a few remarks regarding the paper by Dr. Shanawani. Well, first of all, I do agree, of course, with the fact that Islam is certainly underrepresented, not only in Medline itself, but in bioethics in general. However, I think, and this is not a critique, not at all, that Medline, though an important tool, is of course not the only tool a bioethicist should use. And the problem is that you take any topic in bioethics or any religion or any group, and if you know something about it and you compare all the material you have with the material that can be found in Medline, you will find that a great deal is lost when you would restrict yourself to Medline only. You would have the most of the important clinical and empirical studies, but all the theoretical, philosophical, and theological discussing would be lacking. And so I think it's extremely important to have these two together, and so not forget the thing that Medline is really concentrating on medical journals, and on journals, and so that the important books also which deal about the foundations are missed. And this is not, I would say, a typical problem for Islam as such, but for any bioethical research, and especially when it deals also with religious aspects. And then a third small remark, I think that what you found out, and I agree completely, this divergence and this great variety in the use of the sources and which sources are present. Of course, this is a reality I do not deny at all, but again, I would say, take any topic and take any religion, or take even a secular perspective on bioethics, and take any specific topic, and then ask yourself, or look at all the articles, what kind of method are they using, what's it for them constitutes the good life, and the ways of finding out what the good life is, and so on. Then you would find the same variety. So again, I would say this is a problem which is clearly present in these articles, but is present in bioethics in general, I would say.
I'll just say that I couldn't agree more. I say in the paper that the decision to use Medline as an example is to a certain degree arbitrary. And in fact I include some references in the paper, in particular one written about 6 years ago by Lukov, Provenzano, Liu, and Turner, that talk about that essentially say in 3,000 words what you just were nicely able to say in only a few, 50 or so. We can always make things longer. The other hand, of course, is that Medline is the primary resource for practicing physicians, and at the risk of sounding like we are on some sort of front line of these issues, I do see that we are stuck at this most intimate, vulnerable moment, where I believe ethics is meant to take place, which is protecting of the most weak. If you look at other ethical constructs, Rawls, for example, and who ethics are meant to protect. So to that end, it is the most important tool in our toolbox. And really, what I'm trying to get at is I'm just trying to invite all of you who don't routinely publish in Medline index journals to throw a couple articles that way and start saying and at least refer to those books that you are mentioning, and to the other, PsycInfo, Web of Science, other databases that are very important, and just basically sort of open the door between the two, because Medline will be the first place that we look, and often the last.
Yeah, well, I agree fully with what you say, but as I'm working both in the Faculty of Medicine and in the Center for Religious Studies, I do cross these lines all the time. And what I find often is that when, for instance, around a specific problem, an international consensus is sought, that the literature will be limited to Medline literature, and that as a result of that, very important sources are missed. And so I would strongly react against this kind of scientism, which is absolutely regrettable, and which reduces the ethical discussion to what can be found in the medical journal, as if the fact that an ethical discussion is present in a medical journal gives it a kind of positive or positivistic value it doesn't have when it's published in a philosophical, in-depth book or something like that.
I agree with that. But
Yeah.
You go ahead.
Sorry, thank you. Actually, since the audience here are physicians and healthcare professionals, the main database to be used for the search is the Medline through PubMed, or the Medline which we pay for it, actually. So, and it indexes thousands of journals in terms of healthcare and healthcare science papers and articles. And I believe, the doctor used also Embase. Did you use Embase as well?
I did not use Embase for this study, to be clear.
Yeah, sometimes when we do a search, we use both Medline and the Embase itself, because Embase a little bit wider. The PubMed is free of charge and anybody can use it, actually. But now what counts here, it counts the search strategy, which we teach to healthcare professionals how to do it, how to use it. So, and I think it's a very good search strategy which Dr. he used. Thank you.
Could I add something on that, Jonathan? I think part of the problem that you're getting at, though, also it deals with what Medline will select to index, both which sources they will index, and then within those sources, which articles they will index. And it reflects a deeper problem in medicine, I would say, where, and I must say I've been struggling with this my entire career, that in medicine the idea of evidence and research are so sort of narrowly defined that scholarship, what we would call scholarship, does not count. And many of the things that we would see as studies that would cite the things that you're looking for, Hasan, would be listed as editorials or opinion pieces, not recognizing the kind of research that uses documentary evidence. And that's a deeper problem, I think, that we all have to do something about.
I just want to say that I'm going to allow this discussion to transgress into our lunch hour for 15 minutes. We'll go on till 12:15 with this. And we have two contributions from the internet that I wanted to read out. Okay. One from Mohammad Khalil, who sends his greetings and oddly thought oddly thought you did a really terrific job presenting the paper. So just wanted to pass that on. And secondly, from Kamyar Hedayat, who says, Dr. Shanawani, how do you propose that Shi'i thought have a broad representation in the bioethics literature? As the author of 5 of the 7 Shi'i articles you cited, I have to say some of the reviewers insisted that we include Sunni viewpoints, which we have done in some of our articles. Otherwise, the article could not refer to Islamic beliefs, but to Shi'i belief. From my perspective, there is a prejudice by Muslim Sunni scholars and Western scholars trained only in Sunni thought in overlooking Shi'i thought.
I don't know how to answer that one. Off the top of my head, put simply, it's the only response that I have to say to that is, as a physician, the majority, based on the Detroit Arab American survey done 2 years ago, that a majority of Arab Muslims in Southeast Michigan are Shi'i, and I need to know what the Shi'i are interested in, and I don't pretend to be knowledgeable on that subject. And more to the point, that those who are interested in the topic of the Shi'i schools of thought, the Ja'fari, the Zaydi, and others, for example, they need to be contributing. I agree, and that there may be a bit of a cultural bias. That cultural bias is not unique to Islam. We've discussed that elsewhere today, but it is particularly apparent with this, and I find that very problematic. For example, Shi'i perspectives on rehabilitation and how it relates to certain concepts. I mean, I think answering that question goes well beyond the scope. But please, if the person who wrote that article or wrote that email, if you'd be so kind as to email me directly, my email address is in the talk and on the article. I would love to continue that conversation, but it goes beyond the scope of today, I believe.
Shabir Alabai from Toronto. I have a question for the discussant and a comment and question for Hassan. My question to the discussant is, how can I get a copy of that book, the 3/4 page ones? No, I'm just kidding. But it surprises me that people try and condense information in that fashion. I guess my question to you, with the humor aside, are you suggesting that that kind of book that gives some insight in a very obviously brief and cursory fashion is less than useful and is better not to have at all, or is it better than nothing? And then I have some questions and comments for Hassan.
Well, as with most tools, it depends on how well trained the person using it is. I mean, I think it can be a very dangerous tool to an untrained person. The problem that I have is I try to get my students to understand that the issue of aggregate description is the same whether you're talking about culture or you're talking about epidemiology. They know, or they should know, that when they have their differential list put together and they're going to start with this possibility because it has a high prior probability, that they can't say that's what this person has. They just start there. And that if they were to say, well, this must be sickle cell because this patient is Mediterranean or African American, that they're not doing good diagnosis and they'll get it wrong a lot. That is not different from knowing, as long as the descriptions are accurate, knowing some trends about cultural groups too. But they don't always see the analogy. I mean, the issue is to get from high quality aggregate descriptions quickly to the person in front of you. And they do know how to do that in a differential diagnosis, and they tend to keep forgetting it when they have the possibility of using a cultural stereotype.
I think there's a need in the community, or perceived need amongst clinicians for quick and convenient absolute truths, and black and white when there often isn't. My comment to Hassan is the notion of peer review in many of these journals is a difficult one, and particularly for some of the things that I've written. Clearly, the reviewers who come back to me are not trained in Islamic bioethics, and a number of them acknowledge that in their review, that I don't have expertise in Islamic bioethics. And perhaps to add to your comment, to invite people to write articles within that will appear in the clinical literature for us to be able to access, is also to participate in the peer review process. I know when I've peer reviewed other articles, there have been significant glaring errors in some of the articles I've had to review for non-ethics journals, for clinical journals that talk about Islamic bioethics, and some of the issues that you've highlighted I can bring up, at least as a peer reviewer with some knowledge. My question to you is, there are three particular elements or components of your analysis that I'd appreciate if you could comment on, in terms of how did these three factors impact on your analysis from your paper. It wasn't completely clear to me, and I'd appreciate some comment. The first is the distinction between a paper versus a letter to the editor, either research paper, review paper versus a letter to the editor, how that impacted on what you perceived as basically criteria for quality almost. The second was the journal that it was published in, whether clinical or more ethics-based, and I think that may have already been alluded to. And the third is the target audience, whether generalists or specialists, whether Muslim physicians or non-Muslim health professionals, and how those things should factor into the writer's thoughts as well as the readers.
Shabir, could you repeat the second one, please? I'm sorry.
That's okay. The second one was the type of journal that it was published in, and how that should impact on your critical analysis, whether a more clinical journal or whether one that, even if it's not in the philosophical side, for example, a journal of medical ethics or those kinds of journals that have strong ethics foci, as opposed to more purely clinical journals like New England Journal and so on.
Sure. I think the second question is the easiest to answer, because it goes towards your other comment about the peer review process, and that is and really to the comment on the intended audience, which is just very simply that you're going to get a certain readership that will be sensitive and sensitive to and aware of certain issues, nuances, subtleties, and will accept, if you will, writer's license and certain assumptions that are being made that perhaps we cannot take for granted in writing about into non-medical journals. George Gopin at Duke always used to talk about writing from the reader's perspective, and he's a rhetorical writer, and I doubt that if we actually queried all of these authors, that any of them would suggest that there's anything but a substantial amount of diversity within Islamic thought or anything. But we make these assumptions that perhaps our readers don't appreciate, and I think that's really the issue. And really, when you obviously we write to an audience, and there are limitations, and physicians are notorious for not necessarily wanting ethical principles to abide by, but a whole bunch of rules to comply to, and that leads to this sort of laminated card cultural competency, that Rakam is mentioning. There are real practical constraints to what I'm asking of this group, and all of these questions reflect that it's not as simple as I'm making it out to be. This is a constructed and arguably arbitrary measure of the quality of bioethics literature in one forum, and you may argue, and we acknowledge this in the paper, that it is perhaps an inappropriate statement to be making, and that the possibility is that we were looking for our keys in the street as opposed to where we actually lost them, and that reality should be acknowledged.
Thank you. I quite concur with Hassan's presentation that there are the papers here or presentations or the articles written about the bioethics, especially in Islamic bioethics, are rather undermined. And I reason that for you is because if you do a literature survey in the Middle East, you find that very, very few papers written about it. So it's really lack on our behalf. So I think I will use this conference, and probably Jonathan will help us on this, is that to use it as a pulpit to reach to these the authors and the organizations, and also to actually allow more windows and room for having bioethics to be established in their journals. That's one thing. And I'd like to ask John directly, is this going to be published, summary of this meeting in any, are you going to publish this work, and what kind of publication, if I may ask you? Thank you.
Immediately, the Journal of Islamic Social Sciences is going to be publishing a report on this conference. That's already been contracted and that's happening. And in addition, we have plans to put together both a journal, special journal devoted to some of the conference papers, and then selected conference papers also in a conference volume. Exactly where this is going to be is very much open to debate, and I think might be one of the appropriate topics for our plenary discussion at the end of the conference. Thank you.
Just a very quick comment. Dr. Tahereh, I really enjoyed your paper. You make important points. I just want to raise one issue. As you say, the less educated Muslims worldwide often live in a cloud of fatalism, as you're pointing out. I think one has to be careful. The less educated Muslim, and I'm coming from my own experience in Pakistan, is also generally poorer, also has very little access to other things. In the people you looked at, those who went to private clinics, for example, would have gotten, I'm sure, much better care, much better attention, compared to those that went to a public sector. Again, my experience is from Pakistan. So I think one needs to be a little careful to, it's not just the less educated Muslim. With the less educated come a lot of other socioeconomic factors, which in fact would leave some of those families to say, this is what God willed. So one has to be really careful about that.
Okay, I have, thank you for the interesting papers. I have one comment to Hassan. To this date, I view the topic of Islamic medical ethics from my experience and trying to publish it as like trying to sell your stepson to someone and say, hey, please adopt it. I can't tell you how many times I wrote to journals and they said, well, interesting, but beyond our scope, or we don't have reviewers for this type of thing, or it took about a year until they did find someone, of course I don't know whom, to do it. So that's about why the quantity, I think, could have been larger had people like me and others been more successful in, and then what the result is, and that's maybe on a personal note, that when you show your CV in your own university, they say, why do you have articles only in conference or in collected volumes and not in referee journals? So it comes back to you the other way. Now, as for the disability issue, which is very interesting for me, Tahereh, I wanted to ask you something. I did find, as you did, that the Quran has two attitudes to the disability. One, that it is God's will, as you found, and the other one, that it is a test, ibtila, but always to someone that God believes can stand the trial. Now, I didn't find almost, except for very few references, that it is a punitive measure, that is a punishment. And from this, I came to my own conclusion that the whole idea towards disability is very tolerant in society because you are not to blame for the fact that you or your child is disabled. The question is, if it is God's will, I wonder if you had any follow-up on those people that quit treatment. Do they view themselves or do others view them as someone who goes against God's will or as someone who failed failed the test? How does the community, how does the family or the parents themselves that decide until now and no more, do they have any theological afterthoughts as regard quitting treatment at one point?
Okay.
Yeah.
Well, thank you very much for your comment and the question. About that you said, I agree with you, and I couldn't find anything about it, that the disability as the punishment, and Islam, unlike the Judeo-Christian, that consider disability or the illness maybe the original sin, but in Quranic only the revenge and punishment for those who were certainly wrong. And as I said, in our clinical practice, we don't have any problem with the understanding people and educated people. They understand everything very well, and they didn't confuse it with the duty of the care. But the less educated people, we have a lot of problem with them, and they didn't they stopped the treatment, and they going to the mosque or where else to get the shifa. They get the shifa from the Allah, and they didn't know that maybe the God can do the health of their children from their hands. And thank you.
Dina Davis, Cleveland Marshall College of Law, Cleveland State. I have a comment and a question. The comment, and I bet David does this already, when I'm teaching law or medical or whatever students, and I want to quickly explode their monolithic stereotype about a religion, I ask them to think about their own tradition and their extended family and compare that with the handy-dandy little book, and that usually does the trick. They realize how silly it is compared to, you know, Aunt Mildred and themselves, and if you can just kind of keep reminding them about that, that I think is really effective. The second thing I want to ask, I don't even know how to articulate this well, so forgive me. But a few years ago, I wrote a very, very long, much too long, article on American legal responses to so-called female genital mutilation, that I call female genital alteration, compared to the lack of legal response to male genital alteration. And I think I did a pretty decent job of finding everything written in English, German, and French, and not Arabic. So maybe there's a whole literature out there that I didn't get. But if I didn't get it, that's true of most people in the West. And I'm just really struck at the paucity of people from the Muslim tradition addressing what was, you know, just a huge public relations problem, if nothing else, in this country, and continues to be so. And the stuff written about Islam and that practice is mostly junk. I mean, it's just ludicrous, you know. Well, this isn't in the Quran, so if Muslims believe it, then they're wrong, you know, kind of stuff. Or this isn't religion, it's culture, so we don't have to respect it. I mean, really ludicrous stuff. And I didn't see anybody, I have to say, speaking from a Muslim point of view, addressing this at all. Now, maybe I didn't find it, but I did look pretty hard. So this may not be important from the perspective of that culture, but from the perspective of the way the West perceives it, it was an important issue, and I think it was a missed opportunity. Thanks.
Jonathan, can I just, on the first part, I'd like to underline that point. And we always start discussions of cultural issues, particularly religion, with a period of self-discovery exercise by the students, and also helping them to think about the culture of medicine, because medicine tends to be assumed as something other than culture. So I agree with the comment.
Lance Laird from Boston University School of Medicine. This is for Tahereh's paper. I was very interested in the topic, and I'm wondering if you can explain why you followed through on investigating the religious motivations or the religious understandings of the parents, when it seems like the clear differences between who followed up and who didn't was based on educational level. Those were the extreme differences between the follow-through and non-follow-through. Whereas whether you believed in God's will, God's revenge, or just a part of life, didn't seem to make much difference one way or the other whether you followed through. The columns, unless I'm reading it wrong, are only one subject apart. They're almost 50-50 in terms of follow through or not follow through, whether you thought it was God's will or not God's will. And 26% in that sort of middle column just thought it was a part of life, which I wondered if it has any theological implications whatsoever. And in your conclusion, you stated that there was no inconsistency between the educated people and their religious beliefs, but I didn't see a connection in the paper or in your talk between what the educated people believed theologically. Were they the ones who said it was God's will? Were they the ones who said it was just a part of life? Were they the ones who said it was God's revenge? And I think this goes back to Dr. Muazzam's comment about fatalism as well. Is it the less educated people who are saying, well, this is God's will, and are they on the non-follow-up side or the follow-up side of the God's will column? So I was wondering if you could just elaborate some of that, and are you planning to do some follow-up with these families and say, and sort of flesh out what their theological understanding and their practical follow-through has been? You mentioned that some of them actually did follow through with other forms of therapy. And I think we, particularly in medical settings, make the mistake of saying, well, if somebody doesn't come to my office, they're doing nothing. Whereas they may be doing all they know to do and the best that they know to do, and that may be alternative forms of therapy.
Okay.
It's going to be a very long question.
So that you will answer one time, yeah. In relation to the question of disability, I think if we analyze the causes of disability, we will realize that most of these causes are preventable. So it's a question of really raising the awareness of these people. It's not only a question of education, it's also a question of poverty, the other socioeconomic factors which were mentioned here. So I think disability has got nothing to do with God or God's will or God's nothing to do with it. Is in most instances due to man-made causes, whether it is doctors' mistakes like delayed second stage can lead to cerebral palsy, you know this, infections and all these things. So I wonder, why should we link a disability to God or to God's will or to God's punishment? Nothing to do with that. It's our duty as doctors to awaken the awareness of the people to the true causes of disability and to their rights in healthcare. Thank you.
Thank you very much for your question and your comment. And I know in my research that the lack between the educated, how can we link it between the educated and the attitude toward God? And I just mentioned it because I was an occupational therapist for 5 years, and this patient, about 83 cerebral palsy family, I know them about 2 years, and every week they coming for the treatment, and for that we talk about their belief and what we can do. And I found that like 63% of them have a positive view, and most of the 63 of them was educated people. And maybe I had to do another table and write that is a right point. And about the point that the doctor Yeah, the doctor told us that I wanted to say only this is the specific research, and maybe another researcher shows something else. But always I had the preoccupation with this question: why the family of the children didn't continue the treatment? And this is only came from my research from the love people in the southern of the city. For that is maybe another research is a different result. Okay, thank you.
I'd like to add on in regard to the last point that I think that it's a serious mistake in understanding patients dealing with existential problems to assume that when they ask questions about God's will, it's because they're unaware that there are intervening material or physical causes. Even if all of disability were preventable, and of course then it still wouldn't all be prevented, but whether we're talking about congenital or acquired disability, thinking of, for example, traumatic brain injury or spinal cord injury in a person who was not wearing a seatbelt, there is no great mystery as to why that person in a head-on collision acquired a disability. But you will have to look pretty hard to find such a patient who does not have serious theological questions about that disability, and even about issues of guilt and apportionment of material responsibility and how that relates to theological issues of justice. And I'm speaking from experience with patient populations here in the U.S., but on the cross-cultural data, I think it's generally true too. So I think it's really important to understand that it's not that the material causes are irrelevant to the theological issues, but they don't preempt them, and they don't excuse either us or apparently our patients from trying to come up with ways of dealing with them that make existential sense.
Thank you very much, David, and thank you to the entire panel.
Really enjoyed the paper.
A few brief announcements. There is some extra space for lunch. If anyone has not signed up for lunch but is interested in joining us, please do see me. Secondly, I understand that a few people are already having to leave, and we bid you fond farewell. I'm sorry to see some